So let's move into the advanced disease setting, and by that I mean borderline resectable and truly unresectable. So this could be regional disease or metastatic disease. And Jonathan, since especially the sort of more regional version of advanced disease is something that we look to you as a surgeon to primarily tackle. How do you look at patients in this, not sort of so much lower stage but higher stage, in terms of thinking about prognostic factors, how well you think you're gonna be able to manage the problem with surgery. Who are the borderline cases where maybe medical oncology or systemic therapy, collaboration might be useful?
Yeah. So usually when I have my conversation with the patient, first I think about if I can resect the disease and what functional and cosmetic deformities or problems I'm going to cause. So that's how I judge whether it's resectable or not. Resectability is almost like a state of mind. I can almost resect anything, but would it be good for the patient to take off an entire extremity? So you have to think about the functional and cosmetic consequences of the resection. Oftentimes, if we have bulky nodal disease that may be approaching the femoral artery, femoral vein, or axillary artery or brachial plexus, in collaboration with the medical oncologist and our multidisciplinary tumor board, we'll employ a neoadjuvant strategy to try to downsize the disease with the plan of going back 4 or 6 months later and planning on surgery, unless there's a absolute complete response and you can't tell if there's any disease there. But in general, the discussion with the patient with the regional disease is, can I resect it? If it can't be resected, then you start employing strategies like limb infusions for extremity and transit disease, TVEC intralesional injections, or systemic therapies.
So yeah, we'll come back to that topic before about regionally appropriate therapies, and TVEC, of course, being a new kid on the block, I think is an interesting point. Maybe this is a time to think about, for those who undergo resection who are, clearly high risk for recurrence, so, bulky nodal, lesions particularly, or even a patient with a couple of intransits but still resectable. Ipilimumab in the U.S. anyway is a new treatment option. So before I go to my U.S. colleagues on how they think about ipilimumab at 10 milligrams per kilogram in the adjuvant setting, maybe a little more neutral perspective from Georgina, where in Australia it's not a licensed adjuvant approach. What do you make of the data with so-called high-dose ipilimumab in the adjuvant setting?
So the phase 3 trial, which was reported, I think it was last year or the year before actually, of ipilimumab versus placebo in patients with stage 3 resected. The bulkiest or the greatest burden of disease would have only been 1 millimeter in a lymph node, right up to resectable stage 3B and 3C. So that's the patient population we're talking about in this trial. Randomized ipilimumab at 10 milligrams per kilogram versus placebo showed a relapse-free survival benefit with a hazard ratio of 0.75. So that's a 25% reduction in the risk of recurrence. However, we don't have overall survival benefit, and in that trial there were some deaths due to treatment. It's very toxic, 10 milligrams per kilogram of ipilimumab. It's not approved for use in Australia, or I don't think in any parts of the world except the US. So it's not an option for us, but even if it was, I don't think there would be much uptake by many Australian medical oncologists, given the toxicity, given the lack of overall survival, well, no overall survival evidence as yet, but that's coming. That might change with an overall survival benefit, because the big question we now have with all these drugs in stage 4 is, well, exposing patients earlier where 50% are actually cured with surgery, are we saving them any time? I mean, if we institute treatment at stage 4, are we curing them then? Which we do believe we're curing patients in stage 4. Is it really worth all this risk benefit? So they're the issues. At this point, I don't think many medical oncologists outside the US would actually take up ipilimumab, even if it was available with the current evidence, given the toxicity and the benefit.